Hello, ladies and gentlemen. I'd like to greet you. Today, you are starting to learn an all new specialty. We call it operative surgery and topographic anatomy. The new specialty. When you are trying to start to learn a new topic, you have to answer a few questions. The first of them are what is this specialty is about and whom this specialty is from. What the topic, what the thing that this specialty is trying to study, trying to learn. So, operative surgery and topographic anatomy. When we are trying to answer these questions, we have to make another questions. The questions are how many methods of treatment are in medicine. You know, there are a lot of issues, options of treatment. We can give our patient some medications. We can perform him surgical procedures. We have to make physiotherapy. We can make patient massage. But how many treatment methods are in medicine? You know, only two. We have only two methods of treatment in medicine. One is the conservative and another is operative or surgical. So our discipline, our new topic, then we are trying to start today, learning the surgical treatment. So the main point of our conversation, of our learning, is a surgical method of treatment. And when we are trying to talk about our new discipline, we have to talk about surgical method of treatment. What is it? What it's from? How it differs from another method of treatment. So it is a main point of our discussion. To keep it simple, a surgical method of treatment is the method of treatment by surgical operations. Not so original, but it's true. But what is a surgical operation? What procedure we call a surgical operation and what procedure makes our activity a surgery? A surgical operation is a complex set of various effects on tissues and organs produced by the separation and connections of tissues for the treatment of diagnosis of diseases. In this definition, it's necessary to pay attention to some key points. The first, modern surgery is not limited to mechanical effect on tissues. To influence human tissues, temperature exposure can be used, radio frequency exposure, laser radiation energy, ultrasound, and many other variants. And all of them are surgery. Surgery not only mechanical action on tissues, but many different variants. Surgical intervention is performed not only for medical purposes but also for diagnostic. The key differences of the surgical method from the conservative, is the connection and separation of tissues, two basic techniques. If we find these two techniques in our procedure, it's surgery. But if we can't find it, it's not a surgical procedure. When we try to speak about surgical method, we can say a very important point. You know, when you try to treat patient by conservative method, you trying to not perform any harm to the patient. You know, when you gave him a medication, you are remembering that we have a toxic dose and you won't do it. Yes, because toxic dose, it's not allowed to patient. So when you give a medication to patient, you think that you don't bring any harm to him. But when you're performing a surgical procedure, you are always bringing the harm to the patient. We call it operational trauma. Every time you're performing surgery, you make a trauma to a patient. You're making harm to a patient. So this is a principal point of surgical method of treatment. And this is the thing that makes surgery. when we are talking about surgical treatment, we have to talk about stages and periods of surgical treatment. And we can find three periods of surgical treatment. The first is preoperative. The main objective of the preoperative period are follows. First are examination and diagnosis. A diagnosis for a surgeon in many ways means indications and contraindications for surgery. Indication is a nosological form that determines the need of the operation. Indications can be absolute, orbital, and relative. If we have a vital indications, refusal to perform the operation threatens the life of the patient. Example of such indications are acute cardiac tamponade, tense valvular pneumothorax, perforated gastric ulcer, acute appendicitis, splenectomy, and many other conditions. But in the presence of relative indications, the decision about the operation is made carefully, taking into account the patient age, its condition, and other issues. For example, Leriche syndrome with the walking distance less than 18 meters. It's not an only science, it's art of decision making, and in surgery this art we call tactics. Tactics is a science about how to make decision if we have to make an operation or have to refuse. My teacher, Professor Ratner, says then the most difficult operation for surgeon is the operation that surgeon refused to make, because it's very hard decision to refuse to stop your surgical activity. The first stage of surgical treatment is operation. Operation is act of surgical treatment. And you know, when we are talking about conservative treatment, it can be continuous, but surgical treatment is a local point in time. Operation has a duration, operation has a date and a time of its performance. So this is a key point of surgical methods of treatment. The stage 2 of surgical treatment, surgical operation, have substages. The first is anesthesia and special events. You know, anesthesia is a part of surgical treatment, and when we are talking about surgery, always we will try to talk about anesthesia. And if we are discussing about some surgical procedure and we are discuss about anesthesia, it's our surgical talk. You can say, we know there are a lot of doctors, anesthesiologists, and this job are to make anesthesia. Yes, but decision how can we give anesthesia is decision of surgeon, because anesthesia is a part of surgical treatment. The first step of surgical operation is anesthesia, and the second one is surgical access. Surgical access is a part of operation, providing an approach to the organ or indication how operation can be performed. Access should be physiological, anatomical, and sufficient to achieve the goal. The generally accepted statement, I suppose by Professor Libov, it sounds like that. In surgery, one must be afraid of poor anesthesia and a poor access, because every surgeon know a lot of operations when these guys have been start from poor anesthesia and a poor access, and result of this operation was poor too. The first part anesthesia, the second one is surgical access, and the third one is operative action, a main part of operation. The main options of the names of operational techniques in Latin and Greek language are comparing the name of the operation. You know these words. I think you have learned these words, but now in surgery we have to repeat them and to understand how can we name the operations. So we say ectomia for organ removal. We say tomia for dissection of the organ. We say resectio for excision of part of organ. We have pyxia when we hem in one organ, for example, a mentum to another. We say raphia for suturing. We say stomia for imposing a fistula. We say anastomosis. For the anastomosis, we say punctio for puncture. We say biopsia for taking material for intravitreal research. We say dilatatio for expansion of the lumen of the organ. We say extractio for extraction. And so a long list of sayings. You can find it in our electronic system, and in a few further learning we will say these names for the main part of surgical technique during operation, and this point giving a name for the whole operation. This is a third sub-period of operation, but it's not the last period. The next period is the exit from operation. The way out of the operation consists of the layer by layer suturing of surgical wound, drainage or tamponade of the cavities. By fire remark, tamponade and wound drainage are just as important an operation as a surgery. It must be remembered that there are no trifles in surgery. Each moment which seems unimportant can ultimately determine the entire result of the operation. So the last point of operation is exit from the operation. And the third big stage of surgical treatment is the post-operative period, from the moment of the operation is completed until the patient is discharged from the hospital. One of the points in this period is removing the sutures from the skin, and you're sure you will do this, and you will learn how to do this. There are few classifications of surgical procedures, and we have to learn each of them. The first is the classification by purpose. By purpose, we can classify all the surgical procedures on two big groups, by curative and diagnostic. Curative procedures can be radical and palliative. Radical is an operation that aims to completely cure the patient. For example, gastrectomy for gastric cancer, cholecystomy for cholecystis. It's categorically incorrect to define a radical operation as aiming at the complete removal of pathological focus, since there are a larger number of reconstructive radical operations. Another point in curative surgeries is palliative. Palliative interventions, not aiming to completely cure the patient, are aimed at eliminating any symptoms of phenomena: nutritional gastrostomy in incurable patients with cancer, draining cholecystomy in the case of general serious conditions, sanitary mastectomy in the case of decaying breast cancer, and so on. Palliative surgery does not mean the impossibility and futility of curing the patient. Often palliative surgery is performed as a stage of an addition to radical treatment. So here is the first classification of surgical procedures by purpose. The second one is the classification of surgical procedures by urgency. By urgency, we can classify operations in such groups. The first one is emergency surgeons. They are made immediately after the diagnostic is made in a place where it was delivered. If in this room now we'll enter the patient with the indications for emergency surgical operation, I will start to making this operation right here, right now. I will stop to making this video and I'll try to make this operation right here, because I have no enough time. I have just second of time. I have no this time, and I have to make these operations. Fortunately, there are a few of operations in this group. For example, acute obstruction of the upper respiratory tract, puncture of the pericardial sac in the case of acute cardiac tamponade, and so on. The second group in this classification is urgent. Urgent surgical activity are produced within a short period of time after the patient arrives in the hospital. In most cases, this time period is 2 hours. So when we diagnose acute appendicitis, the patient should be operated in the first 2 hours. Another examples of urgent surgeries are acute peritonitis and perforation of gastric ulcer and so on. The third point is planned operations. Planned operations are performed after complete perioperative preparation at a time that is convenient to organizational reasons. This doesn't mean, however, that a scheduled operation can be delayed indefinitely. The vicious practice of waiting for planned surgical treatment in some outpatient facilities here in Russia still leads to an unreasonable delay in the indicated operations. Thus, most cancer operations are planned for the moment of detection of malignant neoplasm to the moment when a patient will be on the operative table. No more than 3 months should pass. Naturally, being in hospital waiting list only benefit the tumor given the time to grow and metastase. The third classification of surgery is a classification by stages. We have a few stages. The first one is one-time operation. The second one is two-moment operation, and the third one is a multi-stage operation. For example, intestinal insufficiency in the patient with intestinal cancer. We will treat this patient in a two-moment surgery. In the first stage, we will make an intestinal stoma to treat the acute problems, and in another stage we will make and removal operation. In addition to this classification, there are concepts of simultaneous operation. Simultaneous operation is the operation when during one operation time several surgical techniques are performed on different organs, not connected with each other. For example, appendectomy and suturing of the ovarian cyst in one patient, made from appendectomy during apoplexy of the ovarian cyst, diagnosis intraoperatively. So here is the example of simultaneous operation. Now I'll try to tell you a very important point, a surgery operations characterization scheme. When you will try to learn new surgical procedures, when we will try to talk with each other about them, you have to use only one scheme, how to learn about surgical operation. This scheme, you can find it in an electronic system, but I'll try to tell it it will be understood. It is scheme how to tell about operation. And when you will be passing any exams, you have to tell about operation by using this scheme. And when you will start working and you will talk with your patient and you will be talking about your procedure, surgical procedure, you have to use this scheme too. So this is the points of this scheme for your attention. The first is indications. The second one is the contraindications. The third one in terms. Terms in this meaning is things that necessary to know the organizational condition necessary for the performance of the operation. The next one is a set of tools for the operation. The surgical tools is one more topic than we will start to learn here in this course, and you can say stop, but it will be a surgical nurse, and it's her job to give me tools for the operation. Yes, maybe, but you have to know what tools you need. No one can understand, they can know what surgical tools you need in your operation. And when you are trying to start a new operation in your clinic, you will go to your surgical nurse and you will tell her, hey Jane, tomorrow I will make a head transplantation. I'd like you to prepare this list of tools and give me this in the this and this list. So you have to know these instruments, these tools, to work with them. Next point is necessary measures of a preparative period. For example, when you are trying to make an operation on abdominal organs, the intestines should be cleaned. And if we are talking about such operation, we have to remember about this. The next point is laying the patient on the operation table. And this is also your job. You know, in surgery, all responsibility is lying on a surgeon, not the nurse, on a surgical assistant, on anyone else. It's your job to put a patient on the table. So how patient will be laying on the table is your job and your responsibility. So you have to know what the variants of the positions are to lay on operative table. When you want to work on the pelvic organs, you will have to raise the foot end of the table to give the patient the position of Trendelenburg. During operations on the perineum, the rectum on the patient is placed in a gynecological position with the legs apart held of the holders. During operations on the organs of the neck, on the head end of the table is sometimes raised, this position called Fowler position. During interventions on the organ of the retroperitoneal space, the patient can be laid on the side, and it's a very big art to put a patient on the side. So if operation we are talking about needs specific laying of the patient, we have to talk about it. The next one is anesthesia. As we know right now, anesthesia is a stage of surgical treatment. So we have to talk about it when we are talking about surgical treatment. The next one is the surgical access. And if we have a different variants of surgical access, we are given here the classification of them. The next one is operation techniques, main operation techniques, and their classification. If in this surgical operation you have a classification. The next one is the exit of operation. It should be noted here whether the postoperative wound is sutured, whether drainage are installed or no. The next point we have to talk is the necessary measures of the postoperative period. It indicates of which the team's sutures have been removed, drainage have been removed, and the same things of postoperative period. And the last one is the dangers and complications of a surgery. The dangers and complications are divided into general, that can be after every surgery. I mean bleeding, suppuration, inconsistency of sutures and so on, and particular characteristics only for this operation. And as well we have talked about intraoperative complications, early and late. So now we understand what operative surgery and topographic anatomy are talking about. If when we are trying to talk about surgical methods, we have to talk about main techniques of surgery. Of course, we have to learn how can we work with the surgical tools, how have we make tissue separation, tissue fixation and exposure, hemostasis, tissue connection. But now in these conditions of pandemic, it's very difficult. So I hope this time will be soon, then we can meet each other, and when we can work and try to make all these aims in the laboratory. So I ask you to read in our electronic systems the points about tissue separation, tissue fixation and hemostasis, and to learn a list of the instruments needed for this activity. I think the time will come then when you can take these instruments in your hand and you can work on cadaveric or animal material to learn how this activity can be done. The next one we have to talk about is the plastic surgery of skin. It's a point of study of the first of this first lesson, and in general the plastic surgery of skin is a part of plastic reconstructive surgery. Plastic reconstructive surgery is a broad sense means operation that recreate the structure of organs. Elements of plastic surgery are inherent in surgical dentistry, orthopedics, vascular surgery, abdominal surgery, and in the narrow sense, plastic surgery is often understood as can be understood as skin plastic surgery. The need for skin grafting arises in the treatment of chronic skin defects, bone injuries, trophic ulcers, bed sores, and fistulas, and simultaneous skin grafting when removing scars, tumors, and tattoos. Organ and tissue transplantation, according to the World Health Organization proposal, is now classified as follows. We can learn autotransplantation, transplantation of one's own tissues and organs, allotransplantation, transplantation of organs and tissues of another person, xenografting, transplantation of animal materials, explantation, implantation of artificial materials. Nevertheless, these discrepancies remain. In recent years, the concept of explantation in literature has often been used for the operation of removing organ for further transplantation. So we can learn a classification of methods of skin plastics. When we are talking about skin plastics, we can find two big groups of methods, of techniques. The first is non-free skin plastic on the feeding leg, and the next one is the free or loose skin plastic. Non-free skin plastic can be divided as local plastic by local tissues, plastic by remote with flap movement, and the combination of different methods. The free skin plastic can be divided by a full layer flap and a split skin flap. Split means the split by the plane. This split is performed by the dermatome, and the classification used the thickness of these plastics. We can find a one-piece flap, flap sieve, and a flap mesh, and all the methods. For example, for methods of Riverdale. But you can say, it's okay. We understand what are we talking when we are talking about operative surgery. It's a science about surgical method of treatments, about making operations, surgical technique. Okay. But what is topographic anatomy? Why are we talking about surgery and anatomy in a complex? I'll try to answer. The operative surgery and topographic anatomy is a science about how to make a surgical operation and on what have we make a surgical operations. If we will start to make surgical operations not on humans but on the guys from Mars, we have to learn another topographic anatomy, because all our surgery are application to the clinical anatomy, to the anatomy studied by surgeon. You know, it's a very interesting point of view, but when you're anatomist and you learn a lot anatomy of the body, and here in Russian School of Anatomy, we are learning each part of the organ divided. We learn vertebra, we learn each muscle divided, so you can learn anatomy very well. And when you start to make a surgery, you will understand that your learning anatomy are insufficient for making surgery. Nikolai Pirogov says, you can be an anatomist and you can learn the body very well. You never will mark the very important points that only surgeon can understand, because you are an anatomist. So we need another anatomy for surgeons, anatomy by the eyes of the surgeons. And this part of morphological science is a topographic anatomy. We also call it clinical anatomy or surgical anatomy, because it's not only topography. Topography is a science about how different organs interfere, how they align each close to another, but it's more wider. When we're talking about clinical anatomy through the clinical experience. What is the scheme of talking about topographical anatomy points? Here is the scheme. When we are talking about area, but topographic anatomy learns not organs and not parts of organs, but areas of human body. When we are trying to talk about area, you have to use such scheme. We have to talk about borders of the region. Then we have to talk about external landmarks. Then we have to talk about layered structure of the region. Our final aim of learning topographic anatomy is to see the human body like transparent. You're looking at the patient and you can see him like transparent. So deep you can understand anatomy, okay? The next one is holotopia. Holotopia and holotopy is a projection of organs and formations of the human skin. The next one is skeletonotopy, the projection of organs and formations of the skeleton. The next one is a syntopia, the relative position of organs in this area. The next one is anatomy of fascia and cell spaces. It's very important to understanding the diagnosis and treatment of suppurative diseases, because it allows us to choose or determine a rational surgical incision in the treatment of ulcers. The next one is blood supply and inervation in the area. The next one is an age and variant anatomy of the region. The next one, the change of anatomical features in surgical pathology, and a clinical and anatomical justification and features of operations in this area. So this anatomy is very complex. Is most complex variant of human anatomy is the clinical anatomy. It's synthetical. It's not breaking by points. It's integrative way of learning. It's very difficult to understand and very interesting, of course. You know, I'm in Moscow right now, and we have a lot of work, hard work, because now in this situation of epidemic, we have a lot of surgical, of hard surgical work, and a lot of doctors are get ill with the new coronavirus, and a lot of patients get heart condition due coronavirus. But I am right here, and I can meet you. But I'm very glad. I'm very glad that I distantly, but I meet new young people who want to learn surgery and who want to learn operative surgery. Surely I'm here in Moscow, you are there, and it will be different for us to make a connection and to make a learning. And I think that my first aim is to tell you how to learn operative surgery. It's not so simple, because there are not one book that you can read and understand it all, and there is no one film that you can see it and it will make you a surgeon. You know, I'll try to send you by electronic system the concept of learning of operative surgery. I think then you will read this concept, you will understand how can you do this. I'll try to write you an instruction. What have you do to learn operative surgery? It's not a simple task. Operative surgery is one of the most complex and difficult parts of medical treatment, but very interesting. So I think it will be very useful for you to have a workbook and to make a notes there, to write in a conspect of the topics you will study, because it will be useful for you to make a preparation for exam, to make a preparation for further learning, and many other theoretical points. You know, a very big part of our work is the practical work, and I believe, I hope, then we can make a small Olympic Games, of surgical Olympic Games, when you will learn some technical issues, and you can improve your technique, and it can be competition who is the better, and it's very interesting. It takes time for us, but I hope then we can do it. But right now, when we have not simple condition, we have to learn anatomy, we have to learn the principles of this discipline, and I hope that we have a lot of time right now, and we will do this difficult work. I'll try to do my best to help you to learn this difficult but very interesting topic of surgical treatment. One more, I greet you from Moscow, from Sklifosovsky Institute, when I'm working right now, and thank you for your attention, thank you for learning operative surgery.